Either they would have had a earlier fracture in the hip or osteoarthritis, which prevents proper positioning for the surgery required. So that is also one of the important histories that you will find. The second important routine history for TRP patient is: are there any other surgical conditions which have occurred because of the straining and the pressure that they have to put to evacuate their bladder? So what other surgical condition can happen because they strain a lot to pass urine?
Obstructive uropathy, sir.
Hernia, sir.
Hernia, very good. Then
Neurogenic bladder, sir.
Hemorrhoids. Okay, they also develop hemorrhoids because of the straining that they do. So you ask for the history, otherwise they won't tell you that. Many of the patients who come mainly for TRP, unless you ask them, they may be having a small bubonocele or a small hernia, but they will not be knowing about it. So you always examine. First they take the history. What are the various types of urination or the characteristics of urine flow that happens in these patients? What are all the various things that happen to the urination?
Difficulty in passing urine.
Actually, it is called hesitancy. Then
Urgency and hesitancy, sir.
Urgency
and hesitancy, sir.
Urgency and hesitancy, or separately hesitancy, later urgency. Then thin stream. Stream becomes smaller and smaller as I usually teach the mnemonic HISFUND, HIS fund. Yeah? So that HIS fund is for hesitancy, intermittent stoppage of urine, thin stream, frequency of urine, urgency of urine, and nocturnal frequency, and dribbling of urine. So all these things can happen. And if the patient says he has to strain a lot and to pass urine, and even after that he doesn't have the sensation of voiding completely, always ask whether he has any bulge in the groin region or whether any bleeding occurs during defecation. Along with constipation, if they have, definitely most of them develop a hemorrhoids also. And another important history you have to ask in these patients is about the frequency of urinary tract infection. Some of them, because of the retention, they develop a bacterial infection, and on and off they go in for repeated urinary infection, which manifests in the form of rigors, fever, myalgia, all those things. And culture proves to be positive with different types of organisms sensitive to different types of antibiotics. And whenever a TURP is planned, it is always better that you make the urine sterile by taking a culture. And if it is infected, you have to give a appropriate course of antibiotics, and then make sure that the urine culture is coming as a sterile urine with no growth, because urosepsis is one of the important complications in the post-op, which can result in mortality and morbidity. And then coming to the problem of permanent pacemaker, permanent pacemaker is the one which is inserted for various cardiac reasons. What is the difference between a permanent pacemaker and AICD?
So permanent pacemaker for conduction and abnormalities, sir.
Very good.
AICD is for mainly tachyarrhythmia, which can lead to ventricular fibrillation.
Excellent, excellent. So there is a small difference between that. So the examiners may ask you this, and which is more safer, permanent pacemaker or AICD for anesthetizing a patient? Which patient can have a very serious complication, AICD patient or a PPM patient?
AICD, sir.
AACD, yes. AACD patients only, because they have the problem of arrhythmia. And if the AACD is not going to function properly, they can develop a very drastic or a very serious intraoperative arrhythmia, which may be very fatal. Okay, so that is the reason why you have to have a clear distinction whether it is a simple PPM, permanent pacemaker, or a automatic cardio defibrillator, which is mainly given for the arrhythmic patients. And all the questions that you asked about the life of it, how it was inserted, how it has been maintaining. And another important thing in the pacemaker is whether the patient is pacemaker dependent or not. Usually, there are two types of pacemakers. One is a constant generator pacemaker, which, irrespective of the patient's spontaneous heartbeat, it delivers certain number of stimulations to keep the heart rate at a particular level. Then there is another type which is called the demand pacemaker, where it is programmed to initiate its stimulation only when a particular heart rate is reached. For example, if the heart rate goes below to 60, then the pacemaker will come to help and improve the heart rate to a preset value of 70 or 72. So that is a very important thing to note down. And the question of using the magnet to make it asynchronous was originally thought it was the important step before taking up patient with for general anesthesia, I mean for surgery and anesthesia. But later on, they have found that it's not necessary to use the magnet all the time, and but always you must have a backup of uh, equipments required for transvenous patients. So that is a must. And in patients with serious underlying cardiac ailment who have had a rhythm correction equipment or the electronic devices inserted, it is better to have the electrophysiologist or the cardiologist along during the surgery, so that any problem can be identified by them more easily than by the anesthesiologist. And lastly, with regard to, you said about spinal, which is considered as the ideal technique, not only to detect the early presence of Turp syndrome, but what are the other advantages of spinal anesthesia for this particular surgery?
Sir, awareness of the patient, we can assess the mental status of the patient
That's what I said.
intraoperatively.
It's easy to detect the TURP status. At that point, I have already told. Any other advantage because
if
of the
if there is any bladder perforation or a peritoneal perforation, he can have a referred pain to the shoulder, and he will be
it will be identified. Patient will be
identified.
able to complain of that. Very good. Then anything else? The
Then
routine behavior of a cardiovascular system after spinal anesthesia, is it conducive for a TURP surgery or not? What will happen to the blood pressure and pulse rate in the
hy-
patient whenever they are
hypo,
administered subarachnoid block?
so hypotension and
There will be
tachycardia.
some amount of hypotension. Very,
Yes.
very rarely you will have a patient who maintains the same blood pressure and heart rate after a subarachnoid block. Okay, and if you
Yes.
are not careful with the volume and positioning, it is done very early. The level ascends up more than the T10
Okay.
what you require. Then the hypotension will be more severe. But the nominal hypotension that happens helps the surgeon in reducing the bleeding in the operative field and gives them a very clear field. In fact, one surgeon with whom I worked for almost 20 years, a urologist, he prefers to have a BP around 90 by 60, so that the usual resections he will be able to do it without the blood messing up all the time. After he completes the resection, he will ask the BP to be raised with the support and make sure that there are no unnecessary bleeders available. So in that way, it will be helpful to the surgeon to have a clear field, coagulate whatever bleeding is happening, and you get a very good relaxed muscles and bladder. Okay? So that is the advantage of regional anesthesia apart from identification of your Turp syndrome at the earliest. And of course, all the questions on TRP syndrome are also possible in the practical examination. But this pacemaker, when it is given as a additional comorbidity in the patient, you must be able to answer all the questions. And supposing your patient refuses regional, you want to give GA, or you are forced to give GA, then what are the disadvantages of giving GA in a patient with pulmonary pacemaker?
In GA, we cannot assess the
Yeah, that is specific to the surgical aspect. But with regard to the pacemaker, do you have any problem with the drugs that you are going to use for inducing GA, muscle relaxants? Will those things cause any problem? Can you use dexamethasone for intubation? If it is an anticipated difficult airway, can you use dexamethasone for a patient with pacemaker for intubation?
no, sir.
Why?
Prakash. So it causes bradycardia and
Bradycardia in the very first dose will cause bradycardia. Only
no,
repeated doses of dexamethasone are supposed to cause bradycardia. That too with pediatric patients, not in adults. What will happen to the patient when you use dexamethasone?
fasciculations.
Fasciculations will happen, muscle fasciculation. Will they not stimulate or will it not be interpreted as a stimulation and the
Yes.
pacemaker may malfunction?
Yes,
It
sir.
may not recognize if the patient's heart is not beating. So dexamethasone is to be avoided, and but otherwise all the other steps of your GA like laryngoscopy, intubation, all these things are not a major problem with regard to that. Only thing your ECG leads and other monitors, how are you going to place them? None of those lines should be very close to the
Close to the
generator.
pulse generator.
Pulse
They should be.
generator. Okay?
Yes,
All
sir.
the diathermy plates or the wet pad that is fixed all should be very well away from the pulse generator machine of the pacemaker. That is a very important thing. And another important thing in EA is, as you rightly said, you cannot rush in fluids in these patients to maintain the blood pressure. There is a hypotension. Why? Why should you be very careful with the fluid replacement in these patients? What will happen if you give the same amount of say 10 to 20 ml per kg per hour of fluid in these patients, like a regular normal patient? What can happen?
So use of
Especially if they
irrigation
have
fluid also.
Pardon?
Use of irrigation fluid also can lead to hyper overload status in the patient.
Overload status.
So
Some amount of absorption will definitely happen because the venous channels are open and the irrigation is occurring at a high pressure. So some amount of fluid absorption will happen. So you must be very watchful, especially patients who have a pacemaker, to improve the cardiac activity. They may be in certain amount of heart failure earlier. So in those patients, if you give too much of pleural fluid from your side, then along with the fluid that is absorbed because of the irrigation, that patient may develop a pulmonary edema on the table. So that is another precaution that you have to keep in mind when you are administering GA. And with regard to another question commonly asked in TURP, how will you assess the blood loss in these patients? Because you are irrigating all the time and removing the tissues. How to assess the blood loss that is happening in these patients?
So HB of the irrigating fluid based on the formula hematocrit of the irrigating fluid by patient hematocrit into ECF minus ECF. Sir.
ECF minus ECF.
ECF minus ECF.
minus ECF. Okay.
Yes.
Any other rough estimate you know of per gram of tissue excised or per minute of resection time?
So 15 ml of fluid per gram of resected tissue
10
is
ml of 10 ml blood loss per gram of tissue. That is why you are asked to restrict the resection to 60 grams. Okay? So 60 into 10 will be 600 ml. In that way, you can remember that the value. That is a permissible amount of blood loss in any adult patient who has a blood volume of 5 liters. Okay, 1/10 of the blood volume can be sacrificed. So 10 ml per gram of tissue resected, or 1 to 2 ml per minute of resection. And that is another reason why you are asked to restrict the time also between 60 less than 60 minutes, 1 hour. Okay, so that also is another way to calculate. I mean 2.5 ml per minute of resection. So 60 into 2.5 will be roughly about 150 ml. So anyway, these are the two rough calculations. And another formula that you can use is the hematocrit multiplied by the volume of irrigated fluid divided by patient hematocrit also. That is the formula, or by the total ECF calculated minus the ECF also is another formula. Okay. So these are